So here is a normal heart. We're looking at the anterior aspect. We see the great arteries coming from the superior aspect of the heart, at the base of the heart. Here's the apex. This is rightward, this is leftward. And as we look from the posterior aspect at the atrium, we see the right-sided atrium, that the atrial appendage is broad-based. When we open up this right-sided atrium, we see that the pectinate muscle extends from within the right atrial appendage outside its confines to the vestibule of the right atrium. This is a morphological right atrial appendage, and this is a right atrium. In comparison, when we look over at the left side, we see that this atrial appendage is much smaller and finger-like. If we open up this atrial appendage, we see that the pectinate muscle is confined within the atrial appendage, and the vestibule of this left-sided atrium is smooth-walled. This is a morphological left atrial appendage and a morphological left atrium. Coming back to the right-sided atrium that we've established is a morphological right atrium. We can see the superior caval vein, which is coming in the superior aspect. Here's the terminal crest, or crista terminalis. The inferior caval vein has been cut, but we can see the eustachian valve here. And looking at the right side of the interatrial septum, we can see this thickened superior portion, which wraps around the posterior aspect. This is the limbus, or the so-called secondary septum. It's important, especially for the interventionalists who may try to percutaneously puncture across the septum, to recognize that this is not, in fact, a septum. If we look at the exterior aspect, we can see that there's epicardial fat, which interposes between the walls of the right side of this structure and the left side of this structure. So this is, again, the so-called secondary septum, or limbus, and it wraps around in almost a C configuration around the floor of the oval fossa. So deficiency in the oval fossa, which is made of the primary septum, is what we call a secundum atrial septal defect. And then anterior to that, and anterior and inferior, is another part of the atrial septum called the anterior-inferior muscular buttress. A deficiency in this would cause a separate defect called a vestibular atrial septal defect. And then if we look at the landmarks of the conduction system, if we open the heart up and view it in its anatomical orientation, we can see the septal leaflet of the tricuspid valve along the rightward aspect of the interventricular septum. And if we draw a line along the hinge point of the septal leaflet, and from the eustachian valve along the eustachian ridge, which overlies the tendon of Tadaro, where these two lines meet is the apex of the triangle of Koch, with the posterior aspect guarded by the mouth of the coronary sinus and the Thebesian valve. And this is the area known as the cavo-tricuspid or cavo-septal isthmus, an area important for atrial flutter ablation. If we come back over to the left side of the atrium, the morphological left atrium, as we've established, we see the pulmonary veins coming in to the back side of this smooth-walled left atrium. And looking at the interatrial septum, it's a little difficult in this specimen to open up, but we can again appreciate the primary septum, which is a left-sided structure, which forms the floor of the oval fossa on the rightward aspect of the interatrial septum. Now coming back over to the right side and looking at the ventricles, here we see a trifolia AV valve. Again, the septal leaflet of the tricuspid valve. Here is the anterosuperior leaflet, and then a portion of the inferior leaflet here, which has been cut, and we see the other aspect of the inferior leaflet here. So this is a trifoliate valve. It's a tricuspid valve. The most consistent feature of the tricuspid valve is that the septal leaflet, there tends to be multiple direct chordal attachments of the septal leaflet to the interventricular septum. So it is inherently more tethered then the anterosuperior leaflet and the inferior leaflet, which are predominantly supported by papillary muscles. The anterosuperior leaflet here by the anterior papillary muscle, and then the inferior leaflet by the inferior papillary muscle. The commissure between the septal and the anterosuperior leaflet is often supported by the medial papillary muscle. And this is highly variable in its location, its degree of development, whether it's hypoplastic, whether there's a single head or multiple heads. However, this is a landmark used for the surgeon to identify where the right bundle branch penetrates into the right ventricle and then courses down here the septomarginal trabeculation and then across the moderator band to the RV free wall. So again, here is the septomarginal trabeculation coursing up, and then it divides into a posterior caudal and an anterior cephalid limb. And within the limbs is a supraventricular crest and the outlet septum. In the normal heart, we can't really distinguish where the outlet septum ends and where the freestanding muscular sleeve or infundibulum begins. So we can see that there's fibrous discontinuity between the tricuspid and the pulmonary valve, and that's related to this freestanding muscular sleeve or infundibulum. And that's different than what we'll see on the left ventricle. And then looking at the trabeculations of the right ventricle, we can see that they're very coarse and thick, and they extend up the outlet towards the pulmonary valve, with the septomarginal trabeculation being the most prominent structure of these papillary muscles. And from the septomarginal trabeculation, we have these other trabeculations coursing to the RV free wall, or the parietal wall, called the septoparietal trabeculations, which in the normal heart are not as prominent as they would be in something like tetralogy of Fallot. Another feature of the right ventricle is that it tends to be triangular or pyramidal in shape. Similar to the left ventricle, it is tripartite. It has an inlet component guarded by the AV valve apparatus, the apical trabecular component, and then the outlet component, which sits within the limbs of the septomarginal trabeculation extending to the great artery, in this case in the normal heart, the pulmonary valve. Again, the pulmonary valve sits on a freestanding muscular sleeve. We don't see any coronary arteries under the leaflets of the pulmonary valve, and this pulmonary artery has been cut, but we would see early bifurcation. We get a sense of it here with the left and the right branch pulmonary arteries. So morphological features of the right ventricle are the trifoliate or tricuspid atrioventricular valve, the coarse trabeculations in the right ventricle, and then the triangular or pyramidal shape. Now coming over to the left ventricle, we see the anterior leaflet of the mitral valve. We see two papillary muscles here, historically known as the anterolateral and the posterior medial. The anterior leaflet of the mitral valve is in fibrous continuity with the aortic valve leaflets, the aortomitral fibrous curtain. So that's different than the tricuspid valve and the pulmonary valve in the normal heart. And that's related to the development and the resorption of the freestanding muscular sleeve, which brings the aortic valve from the right side in development. We start as double outlet right ventricle to sit over the left ventricle. In this heart, the posterior leaflet is not as well appreciated. If we look back here at the left AV valve, a portion of it's been cut away, but we can see here the posterior leaflet, or the mural leaflet of the mitral valve. And then if we try to look en face at this valve, we can see that it opens in a bifoliate fashion, as opposed to the tricuspid valve. And we also see that unlike the tricuspid valve, which has septal attachments, primarily with the septal leaflet. The mitral valve does not have septal attachments to the left ventricle. So the left ventricle is known as septophobic, where the right ventricle is septophilic. If we look at the trabeculations, they're very fine, lacy, crisscross trabeculations, and predominantly in the apical trabecular component of the left ventricle. And leading to the outlet of the left ventricle, it's a very smooth septal wall of the outlet of the left ventricle. And then looking at the great artery, we can see that there's coronary arteries underneath the leaflets of the aortic valves. There is the right coronary artery, and then here is the left coronary artery. So this is a aortic valve, and this is a aorta. And the aorta has been cut, but then we would see head and neck vessels from the aortic arch. And coming back to the left ventricle, the other feature, so we've established it's devoid of septal attachments. It has fine, lacy, crisscross trabeculations. The other feature being that it tends to be bullet or prolate ellipsoid in shape, which is different than the right ventricle. Obviously, this is one of the least consistent features, since any hemodynamic derangement can change the shape of the ventricles.